I'd like to welcome Henry Strick, who works as a psychotherapist in private practice in London and has a background as an international businessman.
Good morning. I'm very glad to be here at this important and excellent conference, and I'm honored to have been asked to speak. I will start talking a little bit about my own identity, and I will invite you to look at that and wonder about what you can sort of see in that, what you can find out about it. I'm Dutch. I'm Muslim. I'm male. I'm a psychoanalytic psychotherapist, but relational, not classical. I'm a psychotherapist, so definitely not a psychoanalyst. And I'm not Lacanian either. Now, I wasn't a Lacanian when I was 2 years old, or I didn't feel I was. In fact, I'm a bit vague about it, and I don't quite remember, but I don't think, to the best of my recollection, that I was a Lacanian. I asked my parents when they were still alive if they were sure I wasn't, and they weren't any real help. Maybe they were embarrassed at the thought too, and did want to spare my feelings and avoid upset in the wider family. I thought a lot about being Lacanian or not during my puberty. I read endlessly. I had one friend with whom I dared share the idea, but in the end wisdom prevailed. I did not come out as a Lacanian. I did not hint at it to anyone. I didn't want to deal with the trouble. By now you may wonder what the hell is going on and why I keep going on and on about being Lacanian or not. Why at a deeper level don't you really care to know about the history of my status as a Lacanian? I submit that that is because you want to hear what I have to say, if anything, and you believe that your evaluation of my talk and of me as a person is only very marginally influenced by knowing that I am Lacanian or not. It is a relatively minor and unimportant qualification of me personally. And how about for myself? For me, it actually is not a real issue, as I would not need to be afraid of being a Lacanian, if I was. It is not included on my passport. No countries ask for it on their visa forms. No countries put the death penalty on being Lacanian. If the British authorities would want to deport me for being Lacanian as opposed to for being Dutch, I would need to accept it. I couldn't plead that I would be exposed to persecution in my home country for being Lacanian. And the authorities could not give me the third degree to force me to prove that I really am Lacanian, as opposed to feigning it in order to get refugee status. And anyway, how would I prove that I'm a Lacanian? It's no different from with me being Dutch, or perhaps Muslim. There wouldn't be bodily markers for it. And you only really would have access to it by asking me, by talking with me. So with this concrete example, I wanted to make you think about how you know someone's identity, about why it matters, and apply that then specifically to the context of gender and trans in today's society. Now, how is it with being female or male? When I appeared, and maybe if some of you have seen me earlier in the conference, was there any doubt in your mind that I was male? But is there now? If I said that I'm a woman, would you believe me? Given the nature of this conference, and that I suddenly wear lipstick and earrings, do you start having some slight doubts about my gender identity? Are you thinking there might be something strange, anomalous, perhaps slightly perverse, something queer about me? Could it be that I'm at least a cross-dresser in private at home? And let's now look for a moment at the language that DSM-5 has found for this. We've spoken about DSM-5 earlier in terms of the proper diagnostic side with gender dysphoria and the criteria. But DSM-5 also produces a lot of fine print and stories about it. So perhaps I would have an atypical gender expression. I could be gender non-conforming. Perhaps I have an emasculinization desire. Or I could be on my way towards developing an alternative non-male, non-female gender identity. All these terms actually are used in the fine print of the new DSM-5. which actually has been in touch with a surprisingly modern series of ideas that witnesses this panoply of linguistic options. However, I submit that before drawing any conclusions from hints provided by my completely superficial and noted non-genital, non-sexual signs, you would want to talk with me first and hear me about myself, rather than first ask me to take my pants down and inspect my genitals. Regrettably, DSM-5 continues to put a lot of emphasis on sexual autonomy, anatomy, on sex characteristics. I will not repeat that. DSM-5 talks about, apart from all this more modern stuff, also talks about biological indicators of male and female, amongst which they then classify sex chromosomes, gonads, sex hormones, and what they call non-ambiguous internal and external genitalia. And note the rapid, very old-fashioned lapse there into Latin rather than English, where you could say genitals instead of genitalia. And despite all this discussion that went into the progressive transition from gender identity disorder to gender dysphoria, the American Psychiatric Association, of course, unfortunately, could not bring themselves to completely scrap gender dysphoria from the manual of mental disorders. Nor could they even once use the word non-binary gender, which appears to be much more typically used these days for genders other than full-on cis male and female. They use all this other stuff, but not these terms. Now, the other horrible reality that I want again to draw attention to, and it has been mentioned yesterday too, is that in fact it is highly dangerous to be trans, as opposed to being Lacanian, which is also a small minority of the world population. There is now finally a start being made to statistically capture the numbers of people being killed because they are trans. The numbers so far identified are already large, and as the reporting becomes better, will be growing. 7 people in the first 2 months of this year in the United States were killed because they were being trans. More than 140 last year in Brazil. And those are the known numbers in 2 countries which at least have some looking at the data. And even some acquaintance with men who like to cross-dress at parties in London will immediately bring out the risk that they run when returning home of being beaten up on the tube on the way back if they don't change into male or invisible clothing. Being trans is being dangerous. How many trans people are there in the world? In the UK, in London? The real scientific answer is, we have no clue. Statistics in the past, until very recently, moved seamlessly from asking how many trans people are there in X country to how many people can we find with a diagnosis of gender identity disorder. But this is not at all the same thing. Only very recently does attention start to be given to people who are in some way gender variant, but who manage their feelings in such a way that they are not identified in statistics or with services, and who are not prepared to take the risks and deal with the disturbance still caused by having a full medical transition, including surgery. These are people who know that their own sense of their gender does not simply coincide with what society or the parents or the authorities seem to determine about the gender they were assigned at birth. And they don't feel an immediate need to do something about it by physically modifying their body. Now, in a number of ways, it is becoming apparent that many more people than identified so far have some discomfort or unease about the gender they were assigned at birth, and have at least some gender variant self-identification. The Gender Identity Research and Education Society, GIRES in the UK, has done some excellent work in this field. They studied it for a few years. The results were published in 2009 and 2011. They give a very broad estimate that perhaps 1% of the UK population may be, as they express it, experiencing some degree of gender variance, of which they think perhaps 0.2% may at some stage undergo transition. Those are really striking numbers. They're very different from anything else that there is in literature. DSM-5, apart from all the language, also always has a little paragraph about sort of estimated prevalence. They talk about so many people, 3, 5, 15 maybe, per 100,000 in the population, who might have, admittedly, gender dysphoria, which they concentrate on. But that's not trans people. Trans people in the sense of really having a clear idea that they are not straightforward cis male or female, that is a much, much larger group. And of these people, a good proportion probably can best be described as having a non-binary gender identity, whether or not they would like to use this word to describe themselves. There are some excellent recent articles about this, published by Meg John Barker, Christina Richards, Tafina Lazarus-Stewart, which I could refer you to, which describe it and use this key word of non-binary gender that is conspicuous by its absence in DSM-5. Now, it will also be useful to add the final distinction between identity and self-experience. For instance, there has been a recent study in Israel, Joel et al. 2013, where it was found that a large proportion of non-queer people in the general population experience themselves in ways that transcend the either-or logic of the gender binary system. So these are people that they have identified by interviews and surveys as having a clear male or female registered identity, which they are okay with, but of the sort of general representative group they studied, about a third experienced their gender at times as different from their official gender identity. So there you have a situation of not sort of feeling that the identity is different, but certainly having some different experiences. This actually accords with my personal experience, that amongst younger people in general in the UK, there's a rapidly expanding sense that gender is more fluid than it was ever thought to be, and either that the gender of self and others does not matter that much, or that it is seen as natural that a person's sense of their gender fluctuates, or is stronger at some times than at other times. My experience is that a substantial number of contemporary people, when given space and a safe listening ear, kind of thing we do as therapists, will be reflective and thoughtful about their self-perception of their relationship to themselves and others as gendered. Many will have some variation, changes, wobbles, idiosyncrasies when they reflect on that. And to my mind, my experience, it feels more like 10 to 25%, or 20%, rather than 1%. But one is very influenced, of course, by the clients one attracts. And this is a category then going beyond what Jair is trying to capture. So you have the narrow group of people with gender dysphoria who want to transition formally, completely, hormone treatment and surgery. You have the larger group of people who clearly perceive themselves to have a different gender identity. And you have people who at times experience something anomalous in their sense of gender. Let's now think a bit more about this transitioning matter and transitioning of the body. In the title of my talk, I said I would talk about the embodiment of gender. So you really talk about sort of making changes in the body, and that you can also formulate as body modification. But body modification is another somewhat loaded term. I wanted to look briefly at 4 groups. Here's one group of the way in which we modify our bodies aesthetically, visually, and in other ways, in countless ways on an everyday basis. We get dressed. Before the advent of civilization, there were probably many human animals who did not dress. We wash, we comb, we otherwise modify the hair on our head. We cut, shave, or remove our hair in various places. We use perfumes and deodorants. We use soap, creams, and forms of makeup to modify the skin, the feel of the skin, its appearance. That's one group. Nobody even thinks about that in terms of its psychological impact of what it says about the person. Then you have the big medically sanctioned group all forms of medically recommended surgery. By definition, they are generally accepted without question, sanctioned by higher expert medical authority as necessary to support her health. So do we question that? We rarely question the ideas of spectacles to correct eyesight, cataract operations, prosthetic limbs. What about their teeth? No one says that to let teeth rot and fall out would be more natural than the usual practice of taking care, going to the dentist and brushing our teeth. But what about years of orthodontic treatment for children in early adolescence to make sure they have attractive teeth and a beautiful smile? Is that necessary for health? Is it natural? But it is rarely criticized by psychotherapists as in need of reflection, if at all. And the same goes for other obvious remedial treatments of things like cleft lips, children born with 6 fingers or 6 toes, port wine stains, birthmarks in the face. As often as not, attempts will be made to repair these without much criticism or debating possibly doubtful unconscious motives, let alone pathology. It is seen as, of course you would want to do something about it, to modify the body in that way. And a bit more pointedly, what is still in this medically sanctioned category, it usually seems to be very okay for cisgender people to have surgical procedures or hormone treatment clearly related to their gendered appearance, and to not have that psychologized or pathologized, but described as medical or natural. Breast reduction for men who are troubled by gynecomastia, they have sort of growing breasts. Hair removal or implants, female breast implants after they've been removed because of breast cancer, taking steroids to influence body shape. HRT in general for people when it does not have a gender-changing aspect. This seems to be fine, it seems to be medical, another category of body modification. Now jump to a more controversial end, aesthetic reasons. Tattoos, piercings, cosmetic surgery, or what sort of more pleasantly is sometimes called by the people who do it plastic surgery or aesthetic surgery. These are the so-called boob jobs of actors, major or minor celebrities and porn stars. And this is where the sort of change starts. Many psychotherapists draw the line here. And whether or not they go to a formal diagnosis or use particularly pointed terms for what is wrong, they will in one way or another be influenced by the thought when seeing someone who does one of these things that there is something wrong, doubtful, questionable about these practices. In this category, you probably can also class male circumcision, female genital mutilation, and intersex surgery. I will not mention them because I think they go too far away from what we're talking about today. And I think it behoves us as psychoanalysts and psychotherapists to consider exactly what we do with our countertransference and our judgments before wading in and exploring clients' feelings about such doubtful kinds of body modification before we do so and find that unconscious to unconscious, body to body, our clients hear loud and clear that we are convinced that what they do or intend to do is wrong, pathological, and that the only successful outcome of psychotherapy would be that our client would see the light, understands the pathological background to their misguided wishes, would get magically access to the right dosage of spontaneous motivation to make the right decision, which inevitably would be not to do these things. This was, of course, also how it worked in the days 50 years ago, that many psychotherapists and analysts reacted like this to clients who would share with them their homosexual inclinations or behavior. If you partly said, all right, I'm not going to overtly make that the goal of therapy, but still in your mind formulating that there is something wrong. That is true about many of the things in these categories. Then there is a fourth category of body modification, the upsetting hardcore side. The one is non-suicidal self-injury, as it has been named by Favazza, who has particularly studied this for more than 20 years, and who in 3 editions of his book describes loads and loads of things in this category, and what he calls as a subcategory of more durable self-mutilation, but where you also need to classify kind of the self-harming. That is a very, very frequent thing that we encounter in practice. But then you have suicide attempts, or of course in a way successful suicide. Then I think you can put in this category also consciously risking self-harm by doing things like boxing, climbing Mount Everest, possibly rugby, pro football, and certain other sports and martial arts, although not everyone would. And then finally, you have the question of more or less superficial, more or less permanent injury risked or actually caused by BDSM kink activities, including erotic auto or allo asphyxiation. And this is where, for the majority of people, and in fact for, I would say, probably a majority of psychotherapy training, there's little doubt that immediately say this needs to be prescribed. So here you have a whole list, a whole range, of course, on the scale from, in a way, good to bad of possible body modification. Now, how can we look at different variations on the theme of bodily change for reasons of gender self-perception, expression, or identity, and compare them with these other acts of changing or modifying the body? And what and who determines whether acts of body modification are right or wrong, positive or negative, pathological, perverse or taboo? I submit, without being able to analyze it or do justice to it in this short time frame, that it is often the body modification of others distant from us that we condemn, and the body modification of ourselves or those close to us, in our family or our in-group or our community, that we will approve of and find natural and evidently reasonable and well motivated. Now let me try to pull some of this together for psychotherapeutic practice. Against this wider background, I personally draw two conclusions about how we as psychotherapists and analysts can think about trans people viewing, thinking and feeling their body and their gender. I would say it is safer, saner, and more respectful to believe that people are in charge of their own bodies and allowed and even encouraged to make decisions for themselves about their body and their gender. And I would say that this judgment includes, or should include, the question whether changes, modifications or adjustments are reversible or not, superficial or profound, visible or not, whether they're outside the skin, include the internal systems and organs, such as hormone treatment and surgery involving genitals or the shape of body parts such as breasts, but also facial characteristics. Just as the revision which has been taking place over the past 20-30 years of the traditional substantial pathologization of the so-called perversions and later paraphilias was a major change and a major challenge to traditional psychoanalytic thinking, seeing the changes that trans people make or think of making to their body's appearance and expression as their private business and not in self-evident need of interpretation or influencing is a radical step that will feel threatening to many practitioners. It is not easy to deal with one's countertransference response in all these cases. But there is, I think, a simple ethical stricture that if you cannot control your personal countertransference, but recognize it as personal, you should probably long-term not work with certain people. And I believe that applies in this case. It applies to working with kinky clients, with gay clients, with bisexual, pansexual and queer clients, with self-harming clients, with suicidal clients, with asexual clients, with clients with eating disorders, clients who are extremely rich, clients who are very poor, clients of ethnic backgrounds that we are unfamiliar with, and clients who are trans. If we as a therapist or as an analyst have a countertransference that is ours and that we feel we cannot control and that sort of really starts moving into the work we do, then we ought to excuse ourselves. And to give you an example of the other side, much as I enjoyed Alessandra Lemma's book of 2010 about body modification, and agree with good parts of it, it will be clear that overall I disagree with the broad range of the conclusions she draws from her work, especially in a quote where she says, from an analytic point of view, we would understand the decision of the patients I will describe in this book to alter their bodies as being guided by the ascendance of a psychotic process in the mind. Here's a very clear example of current contemporary, I believe as a person really estimable and lovely and effective colleague of ours, who in a book that has been read quite a bit makes this conclusion about essentially all body modification. Now, if you think like that about body modification, it's not so easy then to think really differently about body modification of whatever nature of trans people. There's a long history of trans people which actually precedes and is certainly not as dependent on the availability of late 20th century models of hormonal and surgical change as is often thought. And it is certainly not only Theresia, as much as a lovely example as he or she was, but there are countless examples before late 20th century medicine that trans people were making changes and that men spent long times of their life as women, that women spent long times of their life as men, and that people operated in different gender positions. For me, the natural position at the moment of sitting with clients who start to talk about their variations and uncertainties to do with gender is to allow for the possibility that they see gender as binary or not. That they may want to make any types of practical, medical, physical changes or not, in private or in public. That they may go in whatever direction they want as to how they present themselves, what pronouns they have others use about themselves, how they dress, how they present, whether they take hormones or not, and whether or not they want to make specific changes to their hair, their skin, their body parts, their organs or not. Now, in a situation like that, it takes factual knowledge of options, experience, and of course empathy and sensitivity, when, how, and to what extent you put in elements of psychoeducation, reading suggestions, participation in some groups or events, or whether direct exploring of issues in therapy would be the best form. But the one thing that, in my opinion, is not called for is to give any degree of importance to the personal judgment and the personalized countertransference of the therapist or analyst about how the client wants to lead their life. Some people consider this a radical view and would ascribe this to existential therapists. I see it largely as an ethical imperative. I have not developed these views in the abstract, purely or mainly based on articles and books. I know and I've known for a long time people in many of the categories and situations I mentioned. And I've worked and continue to work with trans clients. And clients who may or may not be trans, but certainly are actively exploring their gender. I follow my clients as much as possible in their journey. I have affirmed as many clients as I could in believing that they could trust themselves and their bodies, far more than today's society, its laws, its culture, the responses of parents, family and religious communities about how they should and should not think about gender. This way of working has rarely if ever been easy, and certainly not easier than a more normative and judgmental position. But I believe it is the only one that is defensible from a position that believes in people being in charge of their own destiny, and that repeating the past can be a deadening straitjacket. My personal views are substantially influenced by the ideas of John Bowlby about the importance of the attachment system of real events and the real relationship, and of the relational emphasis in contemporary psychoanalytic practice. Now, in conclusion, I've said that I think there are, as Joe Clifford said yesterday, many genders and many more trans people than hitherto identified. I think people should be free to modify their bodies without psychotherapists and psychiatrists ready to diagnose, pathologize, or otherwise police them. I believe that our psychotherapy profession should readjust its sights to take a lot more interest in people who are non-standard in their gender experience or identity than is achieved by mainly thinking about people who do want to modify their body. Although if they do want that, let them do so, and let us support them in what they want. I believe some of what I say may feel uncomfortable to some of you. Lacan, who has inspired many of the organizers of this conference, took the view that every age needs to look at people, society and reality in its own new original way. And Lacan himself never shied away from controversy. So, I leave it with you. Am I Dutch? Am I Muslim? Am I male? Am I Lacanian? It is for you to judge if you need to. Thank you.
Thank you, Henry. Thanks for this, I think, very important intervention at this stage of our conference, and also a strong ethical challenge to practitioners. We wanted to mention that Alessandra Lemmo, who of course we invited, unfortunately couldn't be here because she's teaching in Rome. It's a hard life. But if she's watching and wants to...
She's on the plane today.
Oh.
If she wants to phone in her response, then we'd be happy to hear.
I've got a response, really. I don't know whether there's a question in this that you might respond to as well, but I find it very stimulating. And I think during the talk I found my inner Lacanian. And to the extent that the one big buzzword in Lacanian thinking psychoanalysis is desire. And there were two other associations with two other great psychoanalytic figures. Wilhelm Reich, who was very often forgotten these days. Well, he was... Ferenczi is another, but also Bion, to the extent that I thought of the O word. In Bion, something happens, and there's a body-mind split as well. Something happens in a session which is not really, can be worked out in advance, can be just picked up, which is a transformation that he calls in O. It's all very mystic. But I think it's possibly a transformation of the body-mind. Something subtly happens to the body and the mind at once. Also, there's the O of orgasm. Reich was very sort of into this, about sort of... it talked about body armour, body character armour. And for myself, I think that I both find myself and lose myself in O, on the couch and in orgasm. Leo Bassani, as a sort of queer theorist, talks about gay men and self-shattering jouissance. And I think that, body modification, possibly in these senses, happens all the time. But there are these other aspects, I think, to do with the inner Lacanian, which keeps saying, desire, desire, desire. What do we want? And do we find ourselves and forget ourselves simultaneously in that? It's the question of what happens to identity when desire gets going, I suppose.
Thank you. I couldn't agree more. I'm not a great Bionian expert myself, but in terms of Lacan and Reich and Ferenczi and Leo Bersani, I would heartily agree that they are people who would be very much in line with the kind of things I'm saying. Yeah.
It's not a question so much as a comment. I thought your talk was really interesting, and I think it's really important to consider ethics, but I find your mention of FGM in the context of talking about aesthetical reasons for body modification, I find that very problematic. FGM isn't a choice. It's not. It's something imposed on a woman, and it actually and they can't have sexual pleasure then as adults. So I find that very problematic to make that association, and I don't think it helps your argument.
Well, that was not what I intended to say, and I thank you for clarifying that, and I fully agree with how you feel about that and how you see about that, what I did is I made a number of 3 or 4 big buckets, and I said in all of those big buckets, in fact, broadly speaking, there is a sense of how you feel about a positive or negative that goes in one direction, but it is rarely controversial, and all of them have exceptions. And indeed, FGM is a blatant exception to that, yes. But I also very much mentioned it in order to leave it out, because it did not follow any of the argument or directly thinking about adult gender identity. But I fully agree with what you're saying.
I just think it's completely, it should be left out entirely of such a discussion.
But it is a body modification, and it is a body modification that is wrong.
Imposed by
yes.
somebody else.
Yes, yes.
All of the other points that you brought up when you mentioned body modification have some agency involved in the person doing the modification. Where agency comes from is another matter, but the people doing the modification have some sort of agency. And usually the people doing the modification are adults. When it comes to FGM, it's a very specific cultural practice that is imposed on children, specifically girls, who have no agency in this, and it's considered a human rights issue.
I agree with you. I fully agree with you. I really agree with you that it is totally wrong on a human rights issue. But not only that, I was not mounting an absolute argument that any modification is wrong. And in particular to say that any non-consensual things being done to a person is being wrong. And very, very particularly, female genital mutilation is deeply wrong. But there are other things also that are wrong. Let us say surgical castration, as it has happened in the past at times, has been wrong.
Can we just agree that maybe leaving FGM out of the discussion would probably be a good way forward here?
That's what I proposed.
No, I don't think we should do that. I think we should be able to bring everything into the discussion. And the reason why this is quite interesting is because perhaps the idea that something's being imposed, the body modification, can imply, if we bring in the unconscious, to all the other forms of modification. So in other words, the psychotherapist might be thinking, this person's getting a piercing, I should just ignore it, which is what your argument is. But actually, I've got this inkling in my reverie in this session that there is some kind of compulsion being involved here, which is not just...
So children compel themselves.
That's different.
That's the whole point. It's not
The
a question
point
of
is
compelling.
agency.
It's a
The
question
point
of
is
thinking
agency, and that's
how
what
we
you're
think.
ignoring.
No, it's not just a question of agency, because he's talking about cultural acceptance. And you've just said that within certain cultures, these abhorrent practices are accepted.
I would note that
So
it's
that's
two
the
men
point
that
that
are
he was
talking
making.
about FGM.
Okay, we have a lady and then Brian.
Yeah, I mean, my question is a serious one as well. I mean, I agree with the concerns raised about FGM, I have to say. I wanted to ask you about the limits of desire for body modification. I mean, if somebody wants to get limbs amputated, to have the head removed, the heart removed, etc., you know, to what extent do kind of medical ethics kick in around, you know, the Hippocratic Oath and the destruction of healthy organs and skin? And secondly, I mean, you started your talk by talking about violence against trans women, which is a serious issue, and I'm wondering how we might address this. It's men who kill trans women, and it's often trans women who are working as sex workers. Do we try to get trans women out of sex work? How would that relate to our more general politics around sex work? Do we educate men such that they address their internalised homophobia and misogyny, such that they don't feel the need to attack and kill trans women? And I think it's important to raise this issue of male violence, which relates also to the question of patriarchy, which is implied in the question about FGM. And so I think if we're talking openly about these things, I think we need to look at the question of male violence.
Yeah. I did disclose and agree that I'm male, and I did not try to go away from that. I agree on the things you're saying, and I think they are very important topics. Yes, certainly the topic of male violence. But indeed, I did not speak about that.
Yeah, I'd like to say that I think it's very important that you included FGM and circumcision, and I would probably include the constant and quite ordinary ear piercing that little girls have at birth in various countries, South America and the Middle East, and it's seen as a lovely thing that baby doesn't feel any pain, so they have the ears pierced in the maternity home usually straight away. Okay. And I think the reason for doing that is that precisely what the ladies here were saying, that I agree with. This could be seen as acts of violence, and yet we do not diagnose the people who perpetrate those acts of violence as psychotic. They will go, if somebody takes their 12-year-old daughter out of school and to Afghanistan or wherever to have, FGM, we might put them in prison for perpetrating an act of violence. We do not diagnose them. So it's seen as a cultural thing rather than as a psychological disturbance, which is why I think it's very important to mention it.
Yes, and maybe one other category in that area is, of course, intersex surgery. Where, again, some people feel that they can make the judgment that something is wrong and that invasive and permanent surgery is being done at babies immediately when they are born and when they cannot sort of consent or think or do anything. I mean, you have a number of sort of categories there, and I also agree with what you're saying, that culture can often be used as a pretext and as an excuse for what in fact is violence. And I agree that violence should be dealt with by sort of legal means and not primarily by psychotherapeutic means.
Henry, I'm just following on from the kind of flow of the discussion, wondering about the body that could be really sick here, and it doesn't appear to be that it's the transgender body, or particularly the lesbian or the gay body or the bisexual body. And following Otto Gross's idea that these sexualities are a protest against something deeply sick and disordered in heterosexuality. And heterosexuality does not appear to be diagnosed. Now, there's the more specific political forms of phrasing that, such as patriarchy. But there appears to be, for Otto Gross, something fundamentally sick and disordered in the heterosexual need to eliminate other sexualities, annihilate them, and just be sadistic and cure them, of course. So that they can all be heterosexual again. And I wonder where that has a place in DSM-5, and certainly what you think of the heterosexual body as a sick body that needs some help, maybe therapy.
Yeah. I like that, and I like the idea. I think these are all things that need to be questioned. Patriarchy needs to be questioned. Heterosexuality needs to be questioned. Simple cisgender identity as automatic and normative and natural needs to be questioned. But whether the way forward is to let the DSM-5 and the American psychiatrists deal with all problems in the world, I'm not quite sure about. Okay, I wouldn't want to put it in their hands. Okay. Yeah.
We have one more question.
Thank you so much. I really enjoyed your talk. Following on a little bit about the sort of political aspects of looking at the discourse with transgender, if we're to sort of strip away some of the normative views of gender identity and encourage and be creative with children who are experiencing a gender journey, let's put it that way, or a curiosity, who decides when puberty blocking medication should be given, and what conversations can emerge when a child is actually experiencing something, and who decides? Because in some countries it's viewed as if the parents are the abusers if they don't encourage puberty blocking medication. So there's some sort of normative influence that's being imposed on a child that may be curious and may later on not be so curious. So it feels to me as if there's a rigidity that's coming the other way.
Yeah. Excellent question. Cannot remotely do justice to it. It would be a useful subject for a whole conference, I would say. But the whole tension that there is between sort of the full consent, the ability to give consent, understanding cultural pressures, parental rights over children, community rights over children and other people, there are huge issues there, and they are very, very important, because the questions of consent and agency and free will and deciding for others are very, very crucial. But again, there's nothing I can say about that that does justice to it. Thank you.
Thank you, Henry.